A very good morning to everyone. I, Dr. Poonam Joshi, welcome you all in our Saturday ACTREC academic class series. Today, our topic of presentation is Postoperative Drug Management for Head and Neck Cancers. It's been taken by Dr. Vijaya Patil, Madam. Madam is professor in Department of Department of Anesthesia, Tata Memorial Hospital, Mumbai. Madam, over to you.
Just a second. Can you see the?
Yes, madam. Yes, madam. We can see the screen.
Okay. So I just wanted to ask the resident, how many of you are actually doing the preoperative eras, or rather, I think you have started with doing the eras, right? In the head neck.
Initially, madam, we are taking, ma'am, all sorts of classes. Like we take anesthesia,
No. So what I'm asking, Poonam, is
no, madam, we had not done that. No, madam.
So you no. So I thought that in head neck you have started practicing eras, has become a standard of care. Is it so?
Yes, madam. I think we are doing that, ma'am. Yes, madam.
Okay. So I'll just take the residents the little bit. So even if the topic you said is post-operative prescription, I'll just start with the pre-op, or rather talk about peri-op. So just remember, this is for the residents, that the blood transfusion in cancer patients is really bad, and all of you are aware. Though there is level 1 evidence only in the colorectal cancer, where there are lots of studies done, it's now coming up in the other fields of cancer as well. So the GI surgery, the stomach, liver, hepatobiliary. There are no studies which have looked at the head neck, but if you look at the principles of or rather the cause why the blood transfusion is bad in the cancer patient is something called as TRIM, or the transfusion related immunomodulation. So blood transfusion per se leads to immunosuppression because of the various factors which are present in the stored bloods, mainly the leukotrienes. And that's the reason blood transfusion given in the perioperative period to the cancer patients can lead to increase in the incidence of distal metastasis or the local recurrence. And that's why we talk about now restricting the blood transfusion in any cancer patient. And if we need to restrict the blood transfusion in any cancer patient, then it comes as there's something called as perioperative blood management, or PBM, which has got main 4 pillars. One is three pillars: pre-op management, intra-op management, and the post-operative management. So when you talk about the major pillar in these cases becomes the preoperative, where you build up the patient's hemoglobin. Hello.
Sorry for that, ma'am. I think somebody just
unmuted. You can hear me, no? No, you can hear me. No?
Yeah. Okay. Yeah, we can hear you, ma'am.
Yeah. So, so the comes is the buildup of the preoperative hemoglobin. So that is the major pillar. Now you know that most of the patients, at least in our hospital, when you see, especially in the head and neck, from the time that you see the patient in the OPD till the patient comes up for the surgery, it's almost a period of 4 to 5 weeks without, that's your median time, right? Sometimes it can be a little longer because you get appointment for the plastic surgeons quite late. So that is a very good period when you can utilize to build up the hemoglobin. Now, many times, even my residents do this mistake, that when they see a patient's hemoglobin is about 11 gram%, they don't label it as anemia, and they are quite comfortable it. But remember, the normal hemoglobin concentration that we generally say is 13 to 15 gram%. Initially, the WHO has said that in ladies or females, because they are inherently anemic because of the various reasons, the normal range of hemoglobin was considered was 12 to 14 and the males 13 to 15. But now they have also changed, and they say whether it's a male or female, your normal hemoglobin level is 13 to 15 gram%. So every patient with hemoglobin less than 13 gram% tells you that this patient may have so sort of normal hemoglobin, but definitely they have got the depleted iron stores. And that's the reason you should start these patients on iron. One of the reasons that you have to, if the patient has got depleted iron stores, what it does is, when the patient bleeds intraoperatively, say the patient has got blood loss of 500, 600, 700 ml, we will say that, okay, my MABL, or the maximum allowable blood loss, is around 2 liters, so I will not replace it. And on what basis do we say we will not replace it? Because we know physiologically hemoglobin up to 8 gram% will provide necessary oxygen at the tissue level. However, when the patient, any person who has got bleeding, or rather even when we go and give the blood donation, the body, in response to that anemia, it will increase the erythropoiesis, and iron storage that is there in the body is a major limiting factor for erythropoiesis. So if your patient is blood introp, even if we assume that, okay, I don't need to give the blood, but the patient's erythropoiesis will increase and the patient will increase hemoglobin, that erythropoiesis rate will depend on how much is the iron storage. So remember, I'm yet to see not more than 5% patients that I've seen a hemoglobin above 13 gram percent. So any patients who come to you in the first visits, it's preferable that you start them on iron supplements, because when you start giving the iron supplement, it takes around 4 weeks for the rise in hemoglobin and 6 to 8 weeks for the complete rise in hemoglobin. But at least you get that lead and you will be able to either replete the iron stores or get some amount of increase in the hemoglobin. So generally, whatever oral iron you give, remember around 10 to 20% is only elemental that gets absorbed. And when you are prescribing the patient, you should prescribe it properly so that you get better iron absorption. So remember, the iron that you get is in ferrous form and the absorption occurs in the ferric form. That's a reduced iron. And that happens, the ferrous to ferric is in the acidic media. So do not ever use enteric coated iron pills. I mean, they were available in between, but I think most of them are withdrawn after realizing this. So give them with the acidic food and on empty stomach. So tell the patient that they can have this iron along with some lime juice or something of that sort so that the absorption is better. But what you have to look at is the compliance and tolerance of your patient. So many times you will prescribe this to the patient, but patient may not take because iron is typically notorious causing lots of GI complications or GI side effects. So you have to spend 2 minutes insisting or explaining the patient why taking iron is good for them. And if the patient says that patient has got any problem or the patient develops any problem because of oral iron, patient should quickly come back to you saying that I cannot tolerate oral iron. And in those cases, you can start the patients on IV iron. Now, just do not give only oral iron, because again, the cases with the head and neck malignancy, most of the times they are, other than the thyroid or parotid, they will have problems with their intake. They will have problems with their food intake. So they will also have develop some amount of deficiency of vitamin B12 or folic acid, which is also required for hemoglobin formation. So start these patients also on tablets which contain more of folic acid and vitamin B12. So we have got these optineuron or vitneuron preparations or the macrobaron 4. So you just go through our formulary and see which are the tablets which contain high amount of folic acid. So don't prescribe any multivitamin because they contain very minuscule amount of B12 and folic acid. So start these patients on iron and B12 and folic acid. And if the patient cannot tolerate the iron, you can give IV iron. So now we have got this iron carboxy maltose. So that is the one which is a very, very safe. Even the WHO has said that you don't need to give test dose or the anaphylactic reaction to iron preparation IV, which was very high in 25-30 years back. Now it does not have this. So you can simply prescribe, you know, in our OPD, if you prescribe the, I don't know about Actrec, but in Tata here, you prescribe to the patient, it will be given in the daycare. So they get it immediately. So very safely, you can give 1 gram of IV iron along with 1000 micrograms of B12 to these patients, because if you look at an adult, average 60 to 70 kilo adult has got 1 gram of iron in storage, the body storage, other than what is there in the hemoglobin. So you can safely give them 1 gram iron. So that's important as a preoperative prescription, that you see to it that every patient gets anemia management and gets the iron prescribed. And this iron supplement that you have advised, it can continue in the postoperative period. Now, patients who come to you with trismus, you can prescribe the iron syrups, so like Hemapod, Orange, whatever you want to, but you need to tell the patient that they have to take a good iron supplement. Now, general iron requirement, most of, as I told you, the elemental iron is much less. So you have to look at every prescription that you give them, what is the elemental iron, and what is prescribed is around 30 to 50 milligrams of elemental iron per day. So you can just see what the patient is, you will give. The second most important part in the preoperative management of these patients is nutritional optimization. I'm sure, being a head and neck cancer, you must have been told about it. But what I have seen is generally that knowledge, what is given, doesn't come into the practice. So these patients will have lots of nutritional components. And again, there are plenty of studies which talks about patients' preoperative nutritional status and their postoperative outcome in terms of healing and in terms of recovery from the surgery. because every surgery, however small, including hernia and hydrocele, it does lead to some called as catabolic effect. Now, this catabolic effect of the surgery, how fast it will get over, or when the patient post surgery patient will switch from catabolic phase to anabolic phase, depends on how major the surgery is. That is, how much is the tissue dissection is handled. So someone undergoing hernia or hydrocele, maybe after 4 or 5 days this catabolism will go into the anabolism. But the surgeries that we do, the extensive surgeries, it may take 4 to 6 weeks for the patient to switch from the regular post-op catabolic response to the anabolic response. And if the patient is in good nutritional condition, these patients will be able to withstand during that catabolic phase. Now, even if you give a good nutrition in the post-operative period, again, this was what initially, again, 20 years back, when we started understanding this catabolic phase in ICU or in post-operative surgical ICUs, we started giving something called hyperalimentation. That is, these patients used to get enteral plus parenteral nutrition. We used to give lots of calories, 2000 calories and all. But again, the studies showed that it has got a negative impact. So what you need to do is, you just need to keep on giving some calories, which will decrease the rate of catabolism. No matter how much ever you feed these patients, the catabolic response will persist till the effect of surgical post-op surgical catabolic effect comes down. And that is only depends on how bad is the, or how extensive is the surgical trauma. So that's really not in your and my hand. So only thing that we can do is build up this patient's nutrition well, so that even if there's a catabolism in the post-operative period, these patients will be able to withstand that. So see to it that these patients get a good nutritional optimization. Those patients where you feel that they cannot take adequately, like many patients will say, yes, we can swallow, we can eat. But if you can take a detailed history, most of the times they'll say, no, I take liquid. And then in that liquid, if you ask them, I take soup or I take milk, that is not a good diet. So preferably get a dietitian consult again in the first visit. But if the dietitians are busy, if they are overwhelmed, you yourself can prescribe. And there are many commercial formulae which are very good formulae, the isocaloric formulae. That is when the feed that the thing that they have given, like, for one scoop use this much of water, it gets into the isocaloric. That is 1 ml will give the 1 calorie. So try to, you can prescribe, like we have got any formula feed that we have got in dispensary, like, you got resource, ensure, there are multiple things. So you can give, tell the patient, even if you are eating, take 8 scoops a day or 10 scoops a day, which will give additional guaranteed 300-400 calories, along with some, depending on 20-25 grams of protein. So you do prescribe them in the early stages. And again, the element of ERAS is, what we do is preoperative clear liquids till 2 hours prior to surgery. So do not give solids. The solids should be given 8 hours prior to the surgery, but they can continue to take clear liquids, which can be in the form of dextrose containing, like appy, or they can take the lime juice, or they can take simple ORS, whatever it is. So that will continue to give them carbohydrates till they go for the surgery, and liquids, or that will continue to maintain their volume, so that we don't have to give more of the IV fluids in the intraoperative and post-op period. So you just, these two things you can follow in the preoperative period, and that will really help the patient. Now coming to the topic about prescribed post-operative drugs, and this is something I really want you to change your practices. So the commonly prescribed drugs that you give are antibiotics, stress ulcer prophylaxis, antiemetics, DVT prophylaxis, analgesia, and previous medications if the patient is on, and other medications, and stat or SOS order. So this is a common template of the post-operative prescribed drugs. And I keep on saying the practice is very varying, and most of the times there are wrong things that is done. So I'm just going to tell you about the principles and why you should, how you should prescribe the patients in the post-operative drug, rather than having a straightforward prescription which is common, or which is used universally for every patient. Now, the most important drug in the post-operative period that you write is the antibiotics or antimicrobial. Again, I would advise all of you to read this article, which is on the clinical practice guidelines for antimicrobial prophylaxis in surgery. I have not seen the revised version or any update on this. So these guidelines have come up with the Health System Pharmacists, the Infectious Disease Society of America, the Surgical Infection Society, and the Society for Healthcare Epidemiology of America. And it's a very, very clear guideline about what surgeries, which antibiotic you should give, and for how long you should give. Okay. So I'll just show you the table which is of our interest. So you can see the second one, which talks about the clean contaminated cancer surgery. So most of the surgeries, again, so the surgeries that you do, is either a clean surgery, that is your surgery. So what is the definition of clean? Clean, contaminated, and contaminated. Clean surgeries are where you do not open up either the genitourinary tract or the gastrointestinal tract. So these are all clean surgeries. They are the surface surgeries. So all your surface surgeries where you do not open the gut comes as a clean surgery. So your thyroids, parotids, just neck dissections are the clean surgeries. And what they recommended is these patients do not need any antibiotic prophylaxis except the one that we give preoperatively. So before the incision, the antibiotic that we give, that is the only dose that is required for the clean head and neck surgery. Okay. And if you are going to place any prosthesis, which we generally don't, if you consider your drain, surgical drain as prosthesis, which is not, but many times people have argued with me saying that our drain is a sort of prosthesis, you can give cefazolin, because what the bugs that you get when you cut through the skin are all gram positive organisms which are there on the skin, the commonly staph epidermis. So you are just covering for that. So your first generation cephalosporin, that is cefazolin, or the second generation cephalosporin, that is cefuroxime, is good enough. Now Clinda is only for the patients who have got the beta lactam allergy, which is very, very rarely needed. So you, again, if you look at it, evidence of strength is C. So the most important is clean surgeries other than the preoperative dose, you do not require antibiotic. Clean contaminated cancer surgeries, which is the bulk of your surgeries, where you do the commandos and intraoral, all the surgeries, because your mouth is also part of the gastrointestinal system, where you are dealing with the bugs, which are the common cells in the mouth. And for them, again, they are most of the times they are the gram positives. So you can go for the cefazolin or cefuroxime along with metronidazole, okay, because you have got anaerobes in the mouth. So that is what is required. And if, I mean, you can use ampicillin augmentin, but you do not require any other drug. So either use cephalosporins of first or second generation along with metronidazole, or use your ampicillin, and that's your strength of evidence is A. So you do not need aminoglycosides. I know there is a study ongoing in your head and neck services where there, I think there are two arms. One is either ampicillin, either cefazolin with metronidazole, or the cefuroxime with metronidazole, or the other arm I think is cefuroxime, metronidazole, and amikacin. But if you look at the guidelines, you do not require, and that level of evidence is A. You have got ample of evidences, so you do not need anything else. So that is what you are, so that is what your major chunk of the search. So remember again, these patients, if you are doing thyroid or parotid, please do not prescribe any antibiotic post-op. If you are doing any other surgery than that, as commando where you're opening, you require cefuroxime with metronidazole or ampicillin. That is the antibiotic of choice. Now, what is the duration of them that you give? So as with adult patients, single dose prophylaxis is usually sufficient. If you feel, if you have got any other issues, you think that our post-op care is not good, our infection control practices are not tight, and if you are worried for any reason, it can be continued for the duration less than 24 hours, regardless of presence of intravascular catheters or indwelling brains. So again, your all patients fall into this category. So these patients, you should give antibiotics only up to 24 hours. And we follow these guidelines introp in the sense, I have not taken out the page, but if you see somewhere it was written that additional intraoperative dosing may be needed if the duration of the procedure exceeds 2 half-lives. So we as a practice, every patient at the end of 4 hours when the surgery is ongoing will get repeat dose of antibiotic. So we are following this. So I think you can safely stop your antibiotics for all these patients after 24 hours. And then if you feel that afterwards patient gives you there are signs of infection, again, you can consider instituting your another antibiotic, but not as a routine practice. You should not be giving the antibiotics for more than 24 hours. Now, why we should be particular about the antibiotic practice? It's the same reason that when you give any antibiotic to the patient, okay, the flora in the body changes, because if you look at cefazolin, it's a very narrow spectrum. It covers only the gram positives. But as you go to the further generations of cephalosporins, like second generation, third generation, the spectrum becomes wide, gets more and more wider. So second generation cephalosporins like cefuroxime also covers the gram negative organisms. Now, what happens when you continue to give this antibiotic for longer period of the time? These gram-negative organisms will develop the resistant mechanism for this. And then next infection will be with the resistant organisms, and you will require the higher antibiotic. And the studies, again, the detailed studies looked at these things and shown that when you give a particular antibiotic to the patient, most of the patients will get the infection with the microbes resistant to that particular organisms, and this resistance may last from 3 to 6 months. So you are making that particular antibiotic useless for next 3 to 6 months, and that's the reason you have to limit the duration of your antibiotic, and you have to decide which antibiotic you are going to give. Now, if you are worried that, I mean, this is not something, because lots of you are MCH, you have been practicing outside, and I know that, no, you generally outside also they give antibiotic for longer time, and then you'll say, no, 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 we don't want to take chance. If you want to look at, always look at the thoracic unit. For the esophagectomy, for the lung surgeries, we do not give antibiotic post-op. The patients get antibiotic only pre-op dose and intra-op dose, not even for 24 hours, and there is no problem with the patient's infection rate. So there is an example in our hospital. So I think you can safely follow this practice. And my earnest request to you that please curtail the practice of prescribing antibiotics left, right, and center. If you get post-op fever, again, I have seen this from the surgeon's side, that if the patient gets second day post-op fever, at the drop of the hat, they'll say, let's hike up the antibiotic. This is infection related. Now, remember that post-op fever and leukocytosis is very common up to 48 to 72 hours. And that fever can be up to 101, 102 degrees Fahrenheit. So if your patient is otherwise fine, is maintaining hemodynamics, there's no, just observe for first 48 to 72 hours. If you feel that patient is looking bad, patient is getting encephalopathic, patient is looking, your looks will tell you that, no, this patient is looking sick, then you can consider hiking up the antibiotics. But at the same time, you just send the cultures, and you may consider using biomarkers like procalcitonin, which is not highly specific, but it has got sensitivity and specificity of around 70%. Remember, drop in white cell count is more worrisome than rise. As I told you, the leukocytosis is a healthy response of the body for the surgery. But drop in count tells you that there is a major problem. So if any patient drops the count below 4,000 in the post-operative period, then you should be little worried. And but again, I'm not saying just go for the the hike up of the antibiotics, but then you can start doing the cultures, look at the other parameters, look at procalcitonin, and then decide whether you want to hike up or continue the antibiotics for these patients. Okay. Now, the other common prescription that I have seen is the prescription of MSET. Now, you usually practice all the patients MSET in the post-operative period. So remember, post-operative nausea, vomiting can occur in the first 24 to 48 hours, and the risk factors are female sex, young patients, use of post-operative opioids, nausea in the post-operative care ward or in the post-operative period. So if you look at your risk factors, our majority patients are males, elderly. So in male, generally they generally don't have the history of PONE, because in the preoperative clinic, we always elicit this history in detail. Okay, so if it is there, we document over there. So they don't have this. In the head and neck surgeries, we do not use post-operative opioids. So these patients do not need post-operative nausea, vomiting, your MSET and ondansetron for a longer period of the time. Each patient, we follow these guidelines. So each patient, based on how many risk factors the patient has got, will get the MSET, and if required, will also get the second agent, that is DEXA. So you please do not prescribe post-op nausea, vomiting cover as a standard for these patients. They do not get any problem. If the patient, if at all still, if you are worried, you can prescribe it as SOS basis, because whatever you prescribe, the nurses will follow. They will not question you. They will not think over it, in spite of we telling nurses that this is the medication which is not required on the routine basis. You please confirm with the surgeons. That doesn't happen. So I'm telling you that please do not write. If at all you are worried, you can write SOS, but the end of 48 hours, you should write stop over there. So at the end of, basically for your patients, 24 hours. So at the end of 24 hours, if your patient is still vomiting, then you have to evaluate and see what is the cause for vomiting, which again, I am sure that not even 1% patients will get. So please do not prescribe these nausea, vomiting medications to these patients in the post-operative drug management. Then comes to stress ulcer prophylaxis. Again, I have seen that all of your patients, you prescribe Pantocid to these patients, 40 milligram OD. Now, if you look at these guidelines, there are 98 guidelines, but they have been revised. And because we did not feel that there is a need, because there's ample of evidence which says, and this is again in the, so we have got ICU and non-ICU, and these guidelines say stress ulcer prophylaxis is not recommended for adult patients in non-ICU setting. Okay, so and if the surgical patients with fewer than 2 risk factors for the clinically important bleeding, you do not use these things. So what are the risk factors that the patients have got for the stress ulcer? Is coagulopathy, if the patient has got thrombocytopenia, or if the patient's INR or APTT is raised. Again, remember, yeah, that I forgot to tell you in the preoperative period, those patients where you think that the nutritional they are bad, they're very likely to have the vitamin K deficiency. So these patients, it will be preferable if you can give them the vitamin K. So you don't need to get their coagulation parameters done only to know these. It is really not indicated in the absence of clinical bleeding. There is no indication to do the coagulation parameters. But you can, again, the way you start the patients on nutrition, you can also give them couple of doses of vitamin K, right? So just to be sure that the patient is not, and that is not going to cause any toxicity and is not going to cause any, or it will, at the most, it will help the patient. So the risk factors is coagulopathy, mechanical ventilation for more than 48 hours, history of GI ulceration or bleeding within 1 hour prior to admission, sepsis, ICU stay more than a week, occult bleeding lasting for more than 6 days, and use of high dose of corticosteroids. So I'm again telling you 99% of your patients will not have any of these risk factors, telling you that the stress ulcer prophylaxis is not useful for them. Now you know that the recent evidence coming up that the pantocid or all these pantoprazole and all the drugs are associated with acute kidney injury, and the long-term use is associated with osteoporosis and fractures. So please do not take these drugs lightly and do not prescribe them unnecessarily. So do not use your regular. Some people feel, okay, my patient is going to be 2 days NBM. I'll ask the people who keep Rosa for a month. They are NBM for a month, or the giants who keep the pollution. They don't take pantocids or antacids. So you do not require, just because someone is NBM, you do not require antacid just because you are giving antibiotics to these patients. So please do not prescribe routine stress ulcer prophylaxis in the postoperative period. Analgesia is the most important medication in the postoperative period. I think your first medication that should come is the analgesic. Now, we had this study done 5 years back as thesis of one of my students, and what we found that the almost 5% patients did not receive orders for the postoperative analgesics, and these were the patients, all the patients belonging to head and neck oncology and plastic and reconstructive units. Most of these patients had orders like as per anesthetist order, but the anesthetist forgot in the busy postoperative recovery unit, and the patient got shifted without any analgesic order written for them. So you have to write the analgesic, and the routine analgesics, I have seen that quite a few have got NSAIDs like diclofenac and paracetamol prescribed on that. But again, if you are aware that recently or every year we get couple of patients coming in with paracetamol, the liver dysfunction post paracetamol, because the patient kept on receiving paracetamol and got in high dose for that particular patient. So when you prescribe these drugs, please consider any contraindication. Now, you know the contraindication for NSAIDs is renal dysfunction, and for paracetamol is liver dysfunction. If you have got patients who are elderly, or if the patients have got pre-existing, or you are giving some drugs which can have concurrent uh, incidence of nephrotoxicity or hepatotoxicity. So if the patient is, for some reason, like you have got a patient who is quite bad, who's going to MRSA or some infection, and you have to put this patient on vancomycin, or for some reason the patient is getting also, like, once in a blue moon is also getting the aminoglycoside antibiotic, which are known to cause nephrotoxicity, please refrain from advocate non-steroidal anti-inflammatory agent. Or someone who has got history of cirrhosis, it is not contraindication for paracetamol, but you have to consider the dose that you are going to give. Are many of these patients are frail patients? So again, you have to give your drugs very carefully. So always prescribe the drug dose as per the patient's weight. So the non-steroidal anti-inflammatory agents, the dose is 1 milligram per kilo per dose with maximum of 3 doses. And the paracetamol is 15 milligrams per kilo per dose for maximum of 4 doses. So please don't prescribe blanket 1 gram paracetamol, QID or TID. Just look at the patient, calculate the patient's weight, and especially in the elderly, be very careful when you're prescribing the analgesia. So I think when the patient gets discharged to the ward, please go through your prescription chart and see that the patient has been prescribed the one of these agents, and then the patient has got pain relief or no. And if you want to prescribe, just look at the dosages. If in any query, if you have got anything, there is no harm in consulting our pain clinic registrar. Then this is the chart, one of the chart that I have just taken photograph, and you can see in this chart, right, the patient is getting anyway. So the analgesic, the perfalgan has been. Now this patient is receiving IV perfalgan. Now this is your head and neck patient. The head and neck patients, you have got rice tube. There is no contraindication to give them enteral. So in these patients, again, even in the post-operative period, immediate post-op patient comes to me in the ICU. I don't need to give IV perfalgan. I can give tablet paracetamol to the patients through the rice tube, where I'm saving. It's almost your paracetamol tablet costs 2 rupees. IV perfalgan costs 150 rupees. So you know how much time, it's 500 times that I'm going to spend money on these patients. So please do not prescribe injections. So these patients can get everything orally, right from the post-operative period and our post-operative period. So please write tablets. The PAN, as I told you, does not need, the MSET does not need, but here someone has prescribed MSET in SOS basis, a good thing. But again, when you write an SOS medication, you have to see to it that you have got maximum dose and frequency written. Because if you write SOS, the patient complains of vomiting, sister will give. Patient again complains of vomiting after 2 hours. Do you want the sister to give? No. So the principles for prescribing is same as the principles that you prescribe for the regular dosages. So for MSET, when you write SOS into the bracket, you should write 4 milligram, not more frequently than 8 hours, not more than 3 doses in 24 hours. So please, whenever write any SOS medication, see to it that the frequency and maximum dosage is mentioned in that. Now, another important part that we saw in our audit were the previous medications in the post-operative period. Now, again, most of our patient is elderly population. They are smokers. They have got lots of comorbidities. And again, more than 60 to 70% of the patients will having some or the other drugs for the cardiovascular or respiratory problem for those conditions on them. Now, the practice with us is we have got, I don't know, I'm trying to stop that practice, but I don't know how to do it, that you have got one chart, which is in the preoperative period, and you get the second prescription chart in the postoperative period. I don't know why we do that. You can think why we are doing that and probably take steps to stop that. But what happens is when the patient comes to you in the preoperative period, most of the times the patient's medications are written. But again, I have seen that they are not written full, because the person who gives the history, many times it's patient who tells you, sometimes the accompanying person, but patient may forget, the accompanying person may not know, may not understand, and may forget. So many times I have seen that there is no full prescription written in the preoperative, and most of the times this preoperative medication thing doesn't get translated into the postoperative drug chart. So in our patient, we saw that 42% patients did not have their preoperative medications written in the postoperative prescription chart, and these were as important as their IHD medications, as their antihypertensive medications, and the other medications for the other diseases. So please see to it that you write, you pay extra attention, and see to it all the previous medications have been ordered in the post-operative period. The best way, even in the preoperative clinic, we insist that patient should come for the admission with all the medications that they are taking to the hospital. You also insist that whatever they are taking to bring it to you, so that if patient has forgotten, if patient has not understood what they have been taken, you know what they have been taking, and then you can write there. Again, we saw that in the patients were written 42.8, that is 43% of the patient had wrong dose and wrong interval of the previous medication. So pay an utmost, because we do not, already the patients have undergone a major surgery. Already we have caused so much of damage or disturbances in their normal physiological milieu. Please do not complicate it by not giving what the body is used to or the what body needs in the preoperative period. So please see to it, please pay attention in your post-operative prescription that whatever the drugs patient is getting post-operative period continues, and in the same dose and same intervals. I know for the OHAs, the oral hypoglycemic agents, there may be some little bit of like, no, till patient is NBM, you will not like to give. When we start the patient orally, then maybe you'll have to look at the blood sugars and then give. But in those things, there should be clear order, and it will be clearly followed that I had written what was the patient's blood sugar in the ward. Unless and until you are particular about these things, it will not happen from the nursing side. We have got little lacunae on the nursing side because of the workload and because of the numbers. We have got very less numbers. So we cannot expect them to be ideal or perfect. So you have to also, there has to be a second mechanism in place in terms of our vigilance, that the important things are not missed and they have been given to the patient. In the post-operative period, again, I understand that Sheil has talked about the fluid and electrolyte management, but that being another important aspect, I'll just spend a slide on that. So you start the enteral feeds to these patients in the post-operative period as soon as possible. Okay. So IV fluids that we give, do not give adequate calories. So suppose if you have got a patient who has undergone surgery, say tongue commando, primary closure, whatever, or larynx, the patient has come to me in the post-operative period. There is nothing that stops me from feeding this patient after a couple of hours, because you have not done anything to the gut. There is no reason why patient should have less peristalsis. There's no reason why patient should not be absorbing the feeds. So these patients' feeds can be started right in the post-operative period. Now, most of your patients who come to us with endotracheal tube, and where we extubate these patients after the next day morning, in those patients, obviously, we do not want to start the feeds, because suppose there's a small chance that patient may require resurgery or may require reintubation for some reason, I don't want patient to be full stomach. So in those cases, we will not. But again, what I'm trying to tell you is there is no reason why the enteral feed should be withheld in these patients. So next day morning, what I have seen most of the time, the orders from the surgical unit, it start half RT feeds, and then the full RT feeds are written a day after. So first post-op day, patients generally, as per your prescription, get half RT feeds, which if I'm in the recovery, I change them to full RT feeds. So please do not write half RT feeds. Patient should be getting full RT feeds, because again, as I told you, these patients are always calorie deficit. So do not add to that deficit more. So start it immediately next day morning. There is no need for the free water or steroid to be given. They should go on clear the your full diet. See to it that the dietitian chart writes contains the diet which has got at least 1.5 grams per kilo of protein and 30 to 35 kilocalories per kg. You insist, because again, the way we have got junior residents, the way you have got junior residents, your dietitians are the junior trainee dietitians, and they may be they may not be prescribing properly. So just spend another 5 minutes going through the dietitian chart. Just look at how much protein the patient is getting for full day and how many calories the patients are getting. And as I told you, start the enteral medications as soon as possible. You save on money, you save on nursing interactions, you save on the chances of bloodstream related infection, because what it happens with the repeated IV medications. Another thing that if you have observed in the post-operative period is most of our patients tend to become hypokalemic. And the reason for that is again that this diet, that oral diet the patients get, many times is potassium deficient, and there may be some other reason where at the kidney level patient may be throwing some amount of potassium to adjust for the acid-base disturbances. So again, you start these patients on Kesol syrup in the post-operative period. And if you do not believe in me, you can just go retrospectively and see your last 50 patients, what has been their post-operative potassium. You don't need to do daily electrolytes for them. But whenever you have done the electrolytes, just look at that, what is their average potassium. The average potassium will be around 3.5, 3.8, which is not normal. The normal potassium should be 4.5 and 4.5 to 5. So you just see to it that these patients are also prescribed Kesol syrup. Now the Kesol syrup that we get contains 13.13 milliequivalents in every 5 ml. So you at least give them 1 milliequivalent, that is the requirement, daily requirement of the potassium, that 1 milliequivalent per kilo per day. So at least see to it that they get 50 to 60 milliequivalents of potassium through their rice tube. So that comes to around 10, maybe around 30 ml, depending on the patient, so 20 to 30 ml. So do prescribe the potassium syrup. As I told you, continue iron supplements. Now, as I mentioned in the beginning also, the blood is harmful. The blood products are not required in the post-operative period. So follow the transfusion threshold. So mostly, and again, in 95% of the patients, the transfusion threshold of 7.5 to 8 gram percent is good enough. They do not require higher transfusion threshold. There are many studies which are done in patients, because initially we used to think that the patients who have got ischemic heart disease, underlying angina, will require a higher transfusion threshold because they cannot increase the cardiac output. But the studies again have been negative. Large randomized control trials have shown even in the patients with IHD, the transfusion threshold of 8 gram percent is good enough. So follow this transfusion threshold. And if you are giving the iron to these patients, most of the time you'll find that you may not require. Do not correct numbers. Do not give FFPs and cryos to the patient just because their INR is high or their APTT is high. Unless if you think that the patient is bleeding actively in presence of abnormal coagulation parameters, only in those cases you will give the blood and blood products. If for some reason you want to give IV fluid, you think the patient is not tolerating, which will not happen in 99% of your patients. But if you are giving, I'm just giving the basic principles which Sheil must have covered. But again, telling you, if you are giving IV fluid, just remember give it a dextrose based, because that will give some calories. Your ringer lactate and normal saline give you 0 calories. So each 500 ml of dextrose based fluid will give you approximately 90 kilocalories. So even if you are giving 2.5 liters of the fluid to this patient, you are approximately giving 400 to 500 kilocalories. I mean, that is good enough to decrease the rate of catabolism. So every post-operative IV fluid has to be dextrose based. The sodium requirement is 1.5 to 2 milliequivalents per kilo per day, and that's the reason what is advocated is 1/3 or half strength DNS, dextrose containing normal saline, to these patients. If you give DNS to all these patients, you land up giving much more sodium. The potassium requirement, I have as I previously mentioned, 1 to 1.5 milliequivalents per kilo per day. So you see to that in your IV fluid, you add that much of potassium. And the requirement of potassium may increase in case of spontaneous diuresis. So if you have got a sick patient who's come to ICU, who has been on ventilator, had developed some complication, now your patient is sort of okay, patient gets shifted to ward from the recovery. But these patients generally during the acute phase of illness will keep on taking lots of fluids. They will have third spacing, they will have tissue edema, but to maintain the intravascular volume, we will have to give some amount of fluid. Now, as the patient starts recovering, the capillary integrity comes back to normal, then the patient starts mobilizing the fluid from the interstitial and intracellular compartment, which has happened during the acute phase of illness. So, and that's the reason the patient starts mobilizing the fluid and then starts throwing and goes into the spontaneous diuresis. So if you find your patient who is having diuresis after very bad illness, their potassium requirement will be much more increased, and these patients will require the higher potassium, where you can go for your daily supplements of maybe 1.5 to 2 milliequivalents per kilo per day. But in those cases, if you find the patients like this who are in spontaneous diuresis, I would advocate that do daily electrolytes, and then based on that you can give their potassium supplements. They also require magnesium, so at least give 1 gram per. This is for the patients who are getting IV fluids, not for the patients who are getting the enteral nutrition. Okay, magnesium 1 gram per day, and volume should be around 1.5 to 2 ml per kilo per hour. That is what will give you the maintenance fluid if these patients require the fluid requirement in the post-operative period. So that's the end of my topic. Okay, the one more this thing that I have seen that you always write this saline nebulization to all the patients, and I don't know why this practice has come up. There's absolutely no evidence for regular saline nebulization. The patients who have got hyperreactive airway, remember the nebulization that you give is the cold water, which is getting fine droplets going into it. So the patients with hyperreactive airway, it actually may precipitate bronchospasm, because when you and me breathe, there's enough time when my air goes through the nasopharyngeal passages, the air gets warmed up, right? When I'm giving this cold saline with that high flow, with that high nebulization thing, those cold droplets directly get deposited on the upper airway, which can lead to laryngospasm or more frequently bronchospasm, especially in patients with reactive airway. And second thing is this, all medical gases that we give are dry gases which lead to drying of mucosa. What happens is when you prescribe the saline nebulization regularly, the sister will start the saline nebulization, which again, if you stand at the bedside and you'll see that within 10 to 15 minutes max, the chamber gets empty. Okay, but the sister is not going to remove that immediately. For next hour, 2 hours, till she finishes other work, then she will come and see, and then she will remove this nebulization. Till that period, patient tend to get these dry gases, especially the patients who have got tracheostomy. So when you are giving something which is not going to be of any use, but that can cause harm, please stop these practices. For your loosening of secretions or the liquefaction of secretions, systemic hydration is most important. So if I'm giving my patient 2.5 liters or 2.5 liters of liquids or the fluid into the system, that's good enough. So what you need to do is just ask the patients to cough, encourage them to cough. Okay. And for patients with tracheostomy, again, in these patients, yes, because the gases are, you are bypassing the nasopharyngeal mucosa, so more chances that even the ambient air will not be getting fully humidified. So in those cases, you can use artificial nose or HMEs. They're the small filters which you can, they call it tracheostomy adapters. So you can fit them on tracheostomy. So when the patient expires, the moisture in the expired gases gets trapped into these filters. And when the patient is breathing in, these gases will get again, will get humidified with that moisture trapped in the moisturizer, and the patient will get the moist air. But again, in these cases, remember that these filters can, if the patient coughs, the mucus can go on these filters and can lead to the obstruction to the breathing. So be careful. So again, depending on patient, you can decide. But what I feel that most of the times for the patients with tracheostomy, either if the patient doesn't have much secretion, you can use these artificial noses, and you can every 24 to 48 hours you can change, or you can ask the relatives or the patient to keep a watch. So just you can tell the patient that if you feel that there's a difficulty in breathing, you just remove that artificial nose. And if you can do that, that is the best thing. But what I'm saying is the regular saline nebulization practice is probably not required. It's useless and it's harmful, which you may stop giving. So that's all in the post-operative prescription and the management. If there are any questions, we can discuss, or you can ask me.
So, ma'am, thank you so much. I think so many of my own myths were busted, and I realized that we really need to rewrite our these prescriptions post-operative as well as, like you said, pre-operative. And I think our residents also, they must be thinking the same. So I would request, like Madam said, if any questions we can discuss. We can discuss directly also.
Yeah. So Poonam, here I can give you one idea which we are thinking. So you can make, if possible, you can make these small stamps, like, pre-operative when patient comes on the first day. So you can make this, so like, where there you have given iron, you have given vitamin B12, you can make these prescriptions of macro. So you can just find out from our formulary. So you go
Okay,
through,
ma'am.
just don't prescribe any B12. You just look through those drugs and see which drugs contain high amount of B12, like, so this macrobiolin and neurobion that I'm telling you contain, or the mecobalamin, these contain 1000 micrograms per capsule of this B12. So you can just
Okay,
find
ma'am.
out which is available in the formulary. So you can make that with the names, you can make that stamp, small stamp, iron and that, right? And you can just put it. So every patient comes pre-op, you put that stamp on. So automatically it will be prescribed, and you can keep these stamps in OPD. Similarly, for the post-operative prescription, maybe you can have this. So you can have just this prescription of iron, but again, the thing is that I don't know how much it will work, because the pre-operative medications have to be handwritten or other things. So you can go through your prescription, see which is the commonest thing that you give, and you can make these small stamps, and you can start using them, so that there's no question. But another request from my side is, just find out why do we have this practice of having two different prescription charts. So we have got one pre-operatively, and then we change in the post-operative period. Why do we do so? And if we can stop it, because it causes lots of confusion.
Correct, ma'am. In fact, I think none of us have actually thought about it. So I think that's a very valid point that we should have the same chart pre and post operatively so that we do not miss the important drugs which the patient is taking anyways for other ailments, for the comorbidities. So, ma'am, I think do are we doing that same at TMH also? Because ACTRAC, though we do
No,
the
yeah,
same, we
yeah.
are the same center, but still we are not following that. That's why I'm
No.
asking.
That's what I'm
Yeah.
saying. Even in TMH, we have got two different charts. And every time I'm raising this issue, that why is it that the pre-op chart is not carried forward in the post-operative period? So the same chart, because see, again, the practice I think is what, that many things are done before the surgery. So you will find that the patient's post-operative chart is written before the patient is operated, and many times the patient comes in-op, the same chart goes in the post-operative period. So maybe our
Correct.
residents are looking at their convenience, or obvious. I'm not blame them, because they are also overworked. So they are just writing. So it's tick mark, like, no, I have done this, so that I will not forget. But I
Correct,
think
ma'am.
that is somewhere down the line is causing the problem. So if don't think about TMH and ACTRAC practice again, now ACTRAC is still a small, which will again grow in another month or so. But now,
Yes, ma'am.
so you can just start this practice right from the beginning, and I hope that then we can imbibe that into the TMH, right? So that is not the
Definitely.
thing. So you can
No,
just
no.
look at
Yeah,
it.
ma'am.
maybe you can just discuss amongst your surgical colleagues all in that
Correct.
that why this is there and whether you can change it.
Yeah, ma'am. I just wanted to ask because I thought if we are already doing that at PMA,
No,
we can just follow that
no,
because we
that's not
have
happening.
always done that.
Not
So, ma'am,
happening.
we'll try to do that, and naturally we'll be taking your suggestions and help also. So,
Yeah.
because that's a wonderful idea. I think there's one question someone has asked, Anshu, that if patient's bowel sounds not heard on POD1, still full RT to be started, specifically in a laryngectomy patient.
Yeah. So the vowel sounds are not must to start the feeds. The other vowel sounds do not tell you that the peristalsis is there or not there. The genesis of vowel sound is you have got fluid in the intestine. So you got small intestine, succus centricus. Now when I talk, when I swallow, that is the time when lots of air is gulped down. It goes into my gastrointestinal tract. So there this my fluid and the air combined together create a sound. Like when you have got, if you see the deep sea which is flow, the deep river which is flowing, you will not hear the flowing sounds. You will hear the sound where the river is shallow at the stone level, because there is lots of churning happening, lots of air gets mixed. That is what creates the sound. So similarly for the GIT, the sound is created only when there is air inside. So if there is no air inside, then there will not be sounds happening. So the patients who have got laryngectomy, especially because you mentioned that, and that's quite common, they will be breathing through trachea. So the swallowing does not happen because major amount of air goes in when I talk and I swallow. So then in those cases, you may not get the peristalsis sound. So now even in the ICU, it's a principle that we never hear for peristaltic sound. We just start the feeds because the patients who are on ventilation, the patients who have got tracheostomy, the patients who are not breathing much will not get these sounds. The second thing is your presence of food is important to give the peristalsis. Your peristalsis is need based. You know, esophagus, when I gulp, then the peristaltic sound comes. So the feeding itself is a stimulus for the peristalsis. Now the patients have undergone head and neck surgery. There is no reason that you will not have peristalsis unless the patient is grossly hypokalemic or the patient has got bad sepsis or something of that reason. So whenever you look at any sign, symptom, or any number or any test, you know that today's mantra is sort of no, think of pre-test probability. So every patient gets this. You think of pre-test probability. Why my patient should get paralytic ileus? What have I done? What is the reason? So that is minuscule or practically none for the patients with the head and neck surgery to get this problem. Okay, having said and done, in my last 30 years, I have seen one patient who post-operatively developed for some reason perforation. Okay, so that is not the norm, that is not the regular thing. So you have to, so whether you have got peristalsis or no, you start feeding. If you are so worried, then instead of starting 80 ml per hour, you can tell sister just give 100 ml instead of, if you, because in the ward these patient gets bolus feeds, right? All head neck patients we give bolus feeds. So tell sister, instead of giving 250 or 200 ml of bolus, you give 50 ml or 100 ml of bolus every 2 hours. And you say whether patient is showing signs of bloating or patient is complaining this abdominal girth, or the more than girth, the patient has got tense abdomen. You look at that. If it is not there, you know that if even though you are not hearing the peristaltic sound, the patient has got good peristalsis and you can safely give full feeds. So please do not auscultate or do not rely on the peristaltic sounds in the postoperative patients for these patients. Yeah. Even for that matter, let me tell you that I generally give the example of thoracic services because those people had guts when we told them that they said, okay, we'll change the practice. So in the post-operative esophagectomy, the next day morning, so the patients come to ICU generally at around maybe 4:35, 5-ish. Next day morning at 8 o'clock, the patients are started on NJ feeds. 20 ml per hour, followed by after 4 hours 40, 4 hours 60, 4 hours 80. So within 24 hours, first post-operative day, my esophagectomy patient who has got open abdomen, laparotomy, handling of bowels get full feeds. And none of these patients get problem. So what I'm trying to tell you is that lots of things are misconceptions, are taboos, and that is something that we feel that, okay, it's happening for a generation, why should I change? Okay? But today is the era. Many times I tell my residents that you are reading the recent literature. You should come and tell me, madam, recent literature says that this is not needed or this is a wrong practice. We should change. And you should make us change. So No, start reading, start following what the recent evidence says.
Definitely, madam. I completely agree. And I'm sure, again, another myth busted right now. Ma'am, another question. Can we give blood transfusion to head and neck cancer patients in few cases where bleeding is active and above which hemoglobin level should we not give the blood?
No, no. So you are telling me actively bleeding patient. So intra-op
Yes, ma'am.
or post-op the
I,
patient.
I think, ma'am, it's about actively bleeding perioperatively. I assume, but not
Okay.
written clearly, madam.
Yeah, that's a
Yeah.
good question. So the patient, if he's actively bleeding, then there is no question of having a transfusion threshold. I will always like to keep transfusion threshold of maybe 9 or 10, because in case this patient again suddenly gets a major blood loss, or if I get blood late, I should have that safety margin. So the actively bleeding patient, when we talk about transfusion threshold, it does not this thing to the apply to the patients who are having massive blood loss or actively bleeding patient. The patients who are, I'm talking about the patients, routine patients. So if you have got a patient, suppose you've got carotid blow or IJ blow that happens in the ward, in those patients, without thought, you should ask for the blood and you should start it. If you have got high drains, okay, so again that I'll say, so you have to look at the drains. So sometimes what happens, even if I get 300 400 ml of high drains and you think of taking this patient into the OT, then you're going to correct that problem, right? So it's like having a 400 500 ml of blood loss. Even if you get high drains, you look at how much is the blood in that, what the color looks like. So it may be 400 ml, but it's not blood. It is maybe 50% diluted blood. So these things you have to consider. Now, one thing that my residents routinely do, and maybe even you can start doing it, is calculating maximum allowable blood loss. So there's a formula for that, where you say the patient's ideal hemoglobin, or rather the patient's present hemoglobin, whatever is there, minus the target hemoglobin, which we generally keep is 8, okay, divided by the average hemoglobin of 2. So consider if patient has got initial hemoglobin as 12 or initial hemoglobin as 11, minus 8 is my target. So 11 minus 8 divided by the mean of, so for the calculation I'll take is 12. So 12 minus 8 divided the mean of 12 and 8 is 10. So 4 by 10 into the patient's body weight into 60, because 60% of the blood volume. So 60 ml per kilo is the blood volume. So weight into 60 or 70, that is what is the maximum allowable blood loss. So you can calculate it, and okay, see, as of now, my patient can still afford to lose 700 800 ml of blood without causing a problem. So this patients, I will, if there is 300 ml or 400 ml of drain, I will just look at it, I'll observe, or I'll take the patient into the OT. But if you think that whatever is looking into the drain is a sentinel bleed, and you expect that this patient can have carotid blow and will have major blood loss, then in those questions, there is again no question of thinking of MABL, ask for the blood. So just understand, when we talk about transfusion threshold or blood transfusion, is for the patients where you have got controlled bleeding or where you have got a cold case in the post-operative period, not the patient who is actively bleeding or where you are expecting a major blood loss immediately.
Ma'am, I think that's the last question. Your thoughts about
Yeah, yes,
DVT
I forgot.
prophylaxis?
I forgot about the DVT prophylaxis. Yes, all of your patients should be getting DVT prophylaxis, Clexane or unfractionated heparin. Now here, let me tell you one thing. Again, I missed it. I'm sorry for that. Till your patient becomes fully mobile. The fully mobile in the terms, you know that the major source for DVT is in the calf. So that is your soleus, calf pump. So for that, patient has to be actively walking where he's contracting the soleus. So generally for first 4-5 days, your patients, even if they are mobile, sort of, they go to bathroom and they come back, they will not be actively walking. So maybe on 5th or 6th day, when you see that patient are actively walking around, maybe you can stop it, but till 4-5 days you give it. But important thing I have to say is, you do not need to give Clexane, the low molecular heparin. Your unfractionated heparin is equally efficient as far as the DVT prophylaxis is given. So the dose of unfractionated heparin is 5000 BD for the weight below 70 kilos, and 50 kilos, and 5000 TDS above the weight of 50 kilos. So that is what is your unfractionated. Why I'm telling you again is the cost effectiveness. Like, for the patient, we say that, okay, the Clexane costs only $250 or $300 per day. What big deal? But when patient keeps on getting all these 250 per day, 250 per day, 100 per day, it adds to the cumulative cost. So wherever, so if you feel a particular patient, especially a general ward patients, which are not very affording, you can easily prescribe them unfractionated heparin. The cost is minuscule. Again, I think that 25,000 unit bulb costs 25 or 30 rupees. So that will last for the 2 or 3 days to the patient. So you can use unfractionated heparin. For the private patients, you can use Clexane. The affording patients, you can use, because For the nursing point, your collection is much better because it's once a day. Here you are going to do twice or thrice a day. But but both are, so if you will meet people, especially the pharma company guys, coming to you and telling you, no, this has shown in the study, this is good, that is good. But you can just ask them the question, can you give me the studies comparing unfractionated versus low molecular weight heparin, that this is better than that for the routine DVT prophylaxis. So just don't get carried away by what the medical reps tell or what others tell. You can, unfractionated heparin is good enough, but do give DVT prophylaxis till the patient is properly mobile.
So, ma'am, actually, routinely at TMH, we are not using prophylaxis in the postoperative period for our head and neck patients. So,
No,
like we ever had an. Okay,
all
ma'am.
patients
So,
get vaccine.
we are using. Okay, ma'am. So, at ACTEC, at least we usually try to, like you rightly said, we need to mobilize them a lot. And we hardly see any such cases, though I think one or two cases we have seen in these 2 or 3 years. So I think again, I think we need to change this practice if we should start these unfractionated heparin for our patients also. I'm just saying that for benefit of our residents also, ma'am.
Yeah, so maybe what I'm
Yeah.
saying is, again, there is, if you look at clinically significant DVT, which has ended up in PE, maybe less, but the
Yes.
patient got very high mortality. So in
Yes.
these patients, what I would suggest is not, because I've seen again on fourth or fifth day, these patients are very mobile. I see them moving around corridor, sitting in the garden and doing all those things. So then they don't need, but first 2 to 3 days, I think it's preferably you give for these patients.
I agree, madam. They usually land up with PE, and then we know that how they land up in that period post after that PE. Most of them succumb. Our two patients had succumbed. That's why I was a bit.
Yeah.
This I was thinking. So, if there is any other question, so then, ma'am, I would thank you for such a wonderful lecture. Actually, I learned so much from this lecture, and I realized that we really need to think about our these post-operative drug management. In fact, our pre-operative also very critically we have to think about it. And so many things probably we are not doing in the right manner, and can really improve upon that. So I really thank you, madam, and we would request you to take some other lecture for us in the future also.
Sure. Thanks, Poonam.
Thank you, ma'am.